I'm Edilberto Amorim, Director of Epilepsy at the San Francisco General Hospital at the University of California, San Francisco. This is the Congress of Neurological Surgeons, Neurosurgery 100. The topic of the talk today is diagnosis and management of acute seizures after traumatic brain injury, with a focus on advanced brain monitoring. I'd like to start by thanking patients and families, as well as my colleagues at the San Francisco General Hospital and the Critical Care EEG Monitoring Research Consortium for their contribution to this presentation. In acute traumatic brain injury neuromonitoring, we are very focused on the diagnosis and management of seizures. Today we will also talk about other neurophysiology phenomena, such as spreading depolarizations, that may contribute to secondary brain injury and TBI. The longer a seizure lasts, the harder it can be to treat it. Therefore, it's very important to have a structured approach to seizure diagnosis and management. Here we have a proposed algorithm to the treatment of convulsive seizures and status epilepticus for you to have as reference. The benefit of an online talk is that you can hit pause now if you'd like to review the details. But now, let me tailor these general recommendations to traumatic brain injury. Many seizures are self-limited and will resolve on their own. However, prolonged seizures should be managed with benzodiazepines. Benzodiazepines should be repeated if seizures continue. If seizures do not resolve after 5 minutes and status epilepticus is diagnosed, initiation of an anti-seizure medication such as levetiracetam or phenytoin should be considered. Patients requiring several doses of benzodiazepines might have decreased level of consciousness and require intubation, so often anesthetics like propofol are started at that time. Anesthetics are very effective in the control of refractory status epilepticus and should be considered in prolonged seizures. Seizures are common after TBI. Therefore, acute post-traumatic seizure prophylaxis is indicated for patients with intracranial injury or those with a Glasgow Coma score inferior to 13. Prophylaxis is usually done with phenytoin or levetiracetam for 7 days. A helpful summary of the literature on acute post-traumatic seizure prophylaxis can be found in the Brain Trauma Foundation guidelines. In this diagram, we summarize the natural history of seizures after TBI and potential mechanisms contributing to epileptogenesis. The first 24 hours after TBI are the most prone for seizures. Therefore, it is recommended to start prophylaxis as soon as possible for patients meeting criteria, as near 50% of seizures happen in the first day. The risk for seizures remains elevated for the first week, and 1 in 4 patients with moderate to severe TBI will develop acute seizures in this period. Up to half of seizures in these patients can be non-convulsive. Therefore, EEG monitoring is essential for diagnosis in patients with altered level of consciousness. Note the second hump in the pink trend I have highlighted in this slide. This is to remind us that seizures can emerge as sedation and prophylaxis are weaned around 7 days after injury. Any seizures occurring after the first 7 days are generally categorized as post-traumatic epilepsy, given the high chance of long-term recurrence. We recommend that these patients are referred to neurology for long-term follow-up. An important take-home point is that seizure prophylaxis for 7 days does not prevent post-traumatic epilepsy. To summarize, 1 in 4 patients with moderate to severe TBI will have seizures, and most seizures happen in the first 24 hours. More than half of seizures can be non-convulsive, and EEG monitoring is essential. 10% of seizures meet criteria for status epilepticus, and advanced monitoring with electrocorticography using depth or strip electrodes can diagnose seizures in another third of patients who don't have seizures captured with surface EEG only. We'll discuss this type of more advanced monitoring next. Let me start with a typical case we see in our emergency room. So this 81-year-old woman was hit by a motorcycle and developed this large left subdural hematoma with significant midline shift. This patient was taken to the operating room and the hematoma was evacuated, and you can see here improvement in the midline shift after surgery. This patient had surface EEG placed, and we observe here significant encephalopathy with diffuse slowing involving both hemispheres, particularly focal slowing on the left hemisphere, where we can also see a breech rhythm related to the cranial defect. While in the operating room, this patient had a strip electrode placed which contained 8 electrodes. You can see here how the electrodes look like from the manufacturer's website. In the top panel, I have again the surface EEG, and in the bottom, I have the ECOG from the strip electrode placed on the left hemisphere. And you can see here there are about 2 spikes per second, and those are very periodic spikes that evolved over time. And this patient did have subclinical seizures. They were not clearly observed on the surface EEG. But in hindsight, if you look very closely, there is a single electrode in the left parietal region, P3, which I have here highlighted by pink arrows. And there is spike buried behind the delta activity. This can be something very difficult to notice, and really the strip electrode that highlighted how epileptiform this EEG was. Remember, the skull and even the scalp can filter the activity, and the surface electrodes might not be able to capture what's happening inside. Here we have an intraoperative image of the strip electrodes placed on the surface of the brain after a subdural hematoma was evacuated. We place the strip electrode adjacent to areas of injury identified intraoperatively, as those are thought to be more prone to seizures. However, we commonly see seizures recorded from regions that are not clearly contused intraoperatively. Therefore, we try to cover part of the frontal and temporal lobe, orienting the strip in anterior to posterior and inferior to superior fashion. Here we have imaging of another patient who had a left subdural hematoma after being assaulted. This patient had a left hemicraniectomy with a strip electrode placed on the surface of the left hemisphere. And he also had a depth electrode placed on the right hemisphere through a quadrilumen bolt where ICP, PbTO2, and CBF monitors were placed. Here we have our quadrilumen bolt and all intracranial monitors that we commonly place on our traumatic brain injury patients requiring invasive monitoring. I'm highlighting here the depth electrode that we use. This is a Spencer electrode. It's about 1.5 centimeters with a 1 millimeter spacing between electrodes. We aim to introduce the depth so the electrodes are just out of the opening of the bolt. Not always all electrodes are going to be in the cortex, and the number of electrodes in the cortex will vary depending on the orientation of the gyrus and the depth placement. In our hospital, we do not do microdialysis, so we pursue oxygen monitoring, intracranial pressure monitoring, and cerebral blood flow monitoring in addition to the depth electrode placement. I selected this case because both scalp and strip electrode did not show seizures. You can see here this patient has encephalopathy. There's a lot of delta slowing on the scalp EEG on the top panel, and the strip electrode shows a very nice gradient of cerebral activity. You can see here the electrodes 1 and 2 are close to the more contused brain, and you can see here that the ECOG is mainly flat. But as the strip electrodes distant from this contused area, you start to see more and more faster components on that EEG. There is some discontinuity. This patient was on propofol sedation, so you can see here around 7:11 there is some loss of fast frequencies on the ECOG, and that's commonly seen on patients that are on sedation. However, this patient was in focal status epilepticus. He had frequent focal seizures involving the right hemisphere, and we could only diagnose that because he had a depth electrode placed. There's nothing on the scalp EEG. And this is a reminder of countercoup injury. So even though you have a more severe injury in one hemisphere and you often have the surgery done on that side, that does not mean that the other hemisphere is not affected by the traumatic injury. One important reminder is that ECOG monitoring in TBI follows some similar principles to monitoring in epilepsy surgery. The location of the electrodes may determine what you're able to see. Here we have an example of a patient with a right temporal contusion who had a right hemicraniectomy and had a strip placed on the right hemisphere. This patient also had a depth placed on the left frontal region, but the tracing below is only for the strip electrode. This patient was having seizures. They were only captured in a single electrode. In the ECOG tracing, the first channel on top has rhythmic evolving activity, while electrodes just few millimeters away had no epileptiform activity. This could mean that this is a very focal phenomena, or that most of the strip was placed away from the seizure focus. The patient had no scalp correlate to this seizures captured in the strip electrode. My personal approach to focal seizures on ECOG without a scalp correlate is to be conservative on treatment and focus on optimizing anti-seizure medications and avoiding escalation to multiple drugs or anesthetics. If there are signs of worsening or other metabolic derangements, time locked to seizures, such as brain hypoxia, worsening ICP, frequent spread and depolarizations, my management assessment will be reassessed and tailored to this individual patient. I have shown some examples of patients who had seizures recorded with intracranial electrodes but missed on surface EEG. The opposite is also true sometimes. This patient had a right subdural hematoma evacuated and a strip electrode placed on the right hemisphere. However, he developed seizures in the right parietal region that could only be captured on surface EEG. This quantitative EEG panel on the right highlights how seizures were recurrent and how they increase in duration over time. The pink arrows indicate the seizure start with an increasing power in the spectrogram panel for the right hemisphere. The pink and white color increases in frequency, so it goes up on the y-axis. Note that these EEG changes become wider over time, as untreated non-convulsive seizures start to become more organized. This is a reminder that scalp EEG may catch most seizures seen with invasive EEG, and that they can also catch seizures involving brain regions not covered by intracranial electrodes. Therefore, EEG can be a very helpful tool for diagnosing seizures in patients with acute traumatic brain injury. Surface EEG and invasive ECOG should not be interpreted in isolation. Important information can be learned from monitoring of ICP, serial blood flow, and oxygenation. In this example, we have a patient that had loss of autoregulation, so every time his blood pressure would increase in the orange line, his ICP, both in the BOLT and EVD monitors, would also increase. It's very important to take all information in context, as well as interventions that are being pursued for this patient. Our second take-home point is that a lot of information about brain physiology is inaccessible without invasive monitoring, and that should be considered in patients with impaired level of consciousness. Another important neurophysiology phenomenon that's very common after TBI is spreading depolarizations. Up to 60% of patients requiring surgery after TBI will develop spreading depolarizations. A spreading depolarization will use 10 to 100 times more energy than a seizure will. Human studies have linked SDs to worse outcome after TBI, and animal studies have shown that SDs can contribute to secondary brain injury. A spreading depolarization is a very slow phenomena happening in the brain. This waveform will last 1 to 2 minutes and travel the brain 3 to 5 millimeters per minute. A depolarization seen on this red tracing can only be recorded with a special type of amplifiers that can use direct current. Depolarizations trigger loss of synaptic activity in the brain, and there is depression of activity. You can observe here on the black tracing in the bottom that the amplitude of the signal will drop after the depolarization and will slowly go up over time. This phenomena is called spreading because it will slowly move across the brain. You can see here this is a compressed array with 4 hours of ECOG data in a patient with traumatic brain injury. The blue line indicates the start of the first depolarization involving the first channel. The pink arrow on the second channel shows that it took several minutes for that depression to happen on the channel that was just a few millimeters away. And the same phenomenon will spread across each of those electrodes across the brain surface over time. It might take up to 10-20 minutes to see a depolarization spread across a strip electrode that's just a few centimeters. Here we have a video of an animal study showing how a depolarization triggered decrease in blood flow. So this is the intact skull of a mice that was genetically modified to respond to a light trigger. So this light trigger that you'll see in the video will trigger a depolarization that will cause ischemia across the brain. The blood flow measure is depicted in the bottom, and you can see that after a few seconds there is a severe drop in blood flow. So the light goes on and you see pallor going across the entire surface of the brain as the blood flow goes down, and then the blood flow resumes. Spreading depolarizations are a marker of poor outcome after TBI. However, not all SDs are the same. Whenever patients have clusters of SDs, which means whenever SDs come back to back in a short period of time, those patients tend to have worse outcomes. Also, depolarizations that cause continuous or persistent depression of the signal and new depolarizations happen and the signal does not return to baseline, those are also associated with worse outcomes. In this example, we have 4 hours of ECOG data from a strip. We're only showing here 4 channels. And you can see here, right after 10 a.m., around 10:15, there is a first depolarization. It takes about 5 to 10 minutes for that to reach the second and third channel. However, by 11, right after 11, another depolarization happens. And you can see that happens over and over again. And then the channel 1, which is the channel closest to the contused area of the brain, you can see that the brain activity doesn't really come back to what it was before. So that's when people are concerned about depolarizations that are happening without return. These purple arrows highlight all times that a depolarization was seen in this patient. The take-home point is that spreading depolarizations are associated with poor outcome after TBI and may contribute to secondary brain injury. We need to learn more from future clinical trials. When it comes to multimodality brain monitoring and traumatic brain injury, it is very important to look at trends and relationships between brain physiology and other systems. It is also important to look at it quantitatively, so response to interventions and changes in patient status can be watched closely. In my practice, I have developed dashboards that allow me to quickly review trends and customize parameters to the individual patient. Finally, it's very important for neurosurgical, neurocritical care, and nursing teams to work together and develop true multidisciplinary guidelines. These patients are very complex, and it's very easy for information to get lost in translation, causing delays in interventions and missed opportunities to advance care. I have here my approach to neuromonitoring, which is tailored to the severity of injury and risk for cerebral failure. You can hit pause and review the details for nursing and monitoring standards stratified by injury severity. Seizures are very common after traumatic brain injury, and they're often non-convulsive. Therefore, monitoring with surface or invasive EEG can be very helpful in identifying those so-called seizures and managing them. Seizure prophylaxis should be pursued for 7 days in patients with intracranial brain injury or those with a low Glasgow Coma score. Invasive EEG monitoring allows for the diagnosis of spreading depolarizations. This physiology phenomena is associated with worse outcomes after traumatic brain injury and may be a target for interventions, which are currently under investigation in clinical trials. Protocols and guidelines for the diagnosis and management of seizures after traumatic brain injury are very important to prevent variability in care for these patients and hopefully improve outcomes for patients with traumatic brain injury.